Today I want to actually look at some of the rarer pathologies, and namely want to be considering the aortic valve variants that we actually will sometimes see. In this term I'm talking about unicuspid and quadricuspid valves. You can also even get 5-leaflet valves as well, less commonly. With quadricuspid valves, there are a couple of different classification types. In terms of the Hurwitz and Roberts, looking at the relative size of the supernumerary cusp. And when you can look at this picture, you can see there are multiple different presentations. You can actually see with the valve in terms of leaflet size as well as leaflet position. In comparison, the Nakamura classification looks at the actual position of the supernumerary cusp instead. And again, from this diagram, you can see there are multiple different presentations in relation to size and shape of leaflets. When we consider some of the features of these quadricuspid valves, the aortic regurgitation is the most common problem in terms of the functional issues people have with these valves, superseding aortic stenosis as being the main presenting complaint. Often these will present later in life as well, with this in terms of 5th to 6th decade of life. They consider the AR mechanism most likely due to unequal shear force stress actually leading to some leaflet fibrosis and incomplete coaptation of the leaflets. There may also be various coronary artery anomalies that can exist with them as well. The aortic root and ascending aortic dilatation can be seen, but less typically aneurysm and dissection. Similarly as well, endocarditis seems to be a rarer phenomenon with the valves. These are just a couple of references I was using for looking at quadricuspid valves. In comparison, the unicuspid valves, with the classification, there's two types which we talk about. We talk about an acommensural and a unicommensural. In simple terms, the acommensural is normally the one seen in infants, whereas the unicommensural will be the one seen in adults in comparison. When you look at the acommensural, it's generally just got a pinpoint middle in comparison, which is why they tend to stenose much earlier, whereas unicommensural has more of this relative oval opening in comparison. When we consider some of the features, there tends to be this bimodal age presentation, so people either present very early, such as with the acommensural type, where they actually are symptomatic with severe AS at a very young age, compared to the unicommensural type, more commonly presenting later in life. Some even say between 3rd and 5th decades of life, and combination of aortic stenosis or possibly predominant with occasional mixed aortic valve disease. The predominant lesion, as I said, is aortic stenosis, followed by AS with associated aortic regurgitation. Must also remember, though, the calcification and degeneration do start earlier and progress much faster than the comparison of bicuspid aortic valves. Continuing on, it may also be accompanied by other abnormalities such as aortopathy or PDA or VSD, or also coronary artery anomalies as well. With their associated aortopathy, they do actually have a higher risk of aortic dissection, and these also can occur earlier compared with the matching bicuspid aortic valve patients. There can also be some other syndromes such as heart-hand syndrome or part of the hypoplastic left ventricles. They talk about an annual incidence estimated about 0.02%, so very, very low. The surgical numbers you actually see tend to be high. Often they'll talk 3 or 4%, but in comparison they're seeing a severe aortic stenosis group. And the truth is that when we're doing an echo, when they've got a big calcified mass, it may be very difficult to really tell the leaflet morphology at that point. These are a couple of the references I've used in terms of looking at unicuspid valves there. There are a couple of cases I'm going to show today. One is a male in his late teens who's known to have some aortic stenosis in this review. In the actual assessment, he did have a velocity of approximately 6 meters across the aortic valve, so a very high mean gradient. In comparison, we've got a female in the mid-40s who's known to have some dilatation and aortic regurgitation with her quadricuspid valve. In comparison, she did have moderate AR but no significant aortic stenosis. In the parasternal long axis view, when you first look at the aortic valve, there's no obvious appearance in terms of the morphology of the aortic valve from this view. When I zoom up it as well, there's nothing sort of classic or typical about that appearance. It does not look like a normal trileaflet valve. It doesn't even look like a bicuspid valve, although sometimes ones with a vertical commissural orientation do have a similar sort of appearance. When I look at the colour flow, though, I can see significant flow acceleration through the valve there, and turbulence in the aortic root. However, when you do go to the short axis view, it suddenly becomes obvious the nature of the valve here with a single round orifice. You can also see, when you look a bit closer, evidence of a raphe up there and up there as well. Surprisingly, there's not a lot of calcification of this valve, and it doesn't appear that significantly restricted. However, as I said earlier, there was a marked gradient actually across this valve. Moving on to the patient with a quadricuspid valve, initially I'll show some standard transthoracic images, but also show some toe images of this same valve. When we look at the parasternal long axis, the aortic valve morphology does look a little bit strange. The leaflet tips do seem a little bit curious when you actually do look at it there. On colour flow, we can see there is a fair amount of aortic regurgitation as well. So when we zoom on the valve, as I was saying before, there is a strange relative appearance of the opening pattern and also of the leaflet tips. When we now look in the short axis, we can see the valve does seem to have a strange appearance. As we look a bit closer, I've got a couple of images here, we start to get the feeling there is actually a relative fourth leaflet there. When I freeze the image, you can actually see 4 different leaflets. Next, I have the transesophageal images, which you can see the leaflets a lot more clearly and a lot more nicely. So we can here see from the equivalent of that long axis view of the valve, again that morphology of the leaflet tips, which just has an abnormal closing appearance. So when we look at the valve in the short axis in comparison, you can just see that nice, relatively equal size cusps there of that valve. And when we zoom up upon that valve, you can see very clearly the 4 different leaflets very nicely presented here. But there's no significant calcification, there's no particular commissure fusion or any other issues of concern. Thank you for watching my latest in this Echo Education series. I'm Marcus, Senior Sonographer from the Melbourne branch of Cardiovascular Services. Thank you again.